3 years or so, and so we'll discuss that also. So, unfortunately, I don't have any disclosures related to this talk, and even more unfortunately, everything that I talk about is unapproved by the FDA. So, in the tradition of U of L Grand Rounds, we're going to start off with a patient. He's a 44-year-old white male. He's a service-connected veteran. This is his second admission for alcoholic hepatitis this year, so that's relevant. Remember that. He drinks 10 to 18 beers a day, so less during the week, more on the weekends. We see this a lot, so he's still working full-time as a maintenance person. He has a 15 to 20-year heavy drinking history. His mother was an alcoholic, and like many of our patients with alcohol-related liver disease, he smokes. On physical exam, his BMI was 31, and so over the time that I've studied alcoholic hepatitis, this has been something that's changed. So we used to see these kind of like skinny little guys with that were very malnourished. Now they tend to actually be overweight, and we'll talk about that. And you can see his laboratory tests here. So his bilirubin was 29, his albumin was low, AST was elevated, but his ALT wasn't. And so that's something that we know, that AST is higher than ALT in alcoholic hepatitis. His creatinine was starting to creep up, and his MELD was 28. And for the diagnosis of severe alcoholic hepatitis, you need a MELD or a model of end-stage liver disease score of greater than 20. And that's driven in large part by the bilirubin and creatinine. So in the next 45 minutes or so, I'm going to give a brief overview of alcoholic hepatitis. We're going to talk about mechanisms and then go into what we're doing now for treatment. So, as I said, there's been a change in the landscape. And so this article was just published in BMJ. Actually, we wrote an editorial to this about the mortality from cirrhosis and liver cancer in the United States. And mortality from cirrhosis over this period of time has gone up 65%. Mortality from liver cancer has doubled. So when most cancers are going down, HCC is going up. Now, our basketball team isn't number one, but Kentucky's number one in the numerical increase every year in liver-related deaths. So Kentucky is now number one, which is unfortunate. This is another article that's in press and shows the trends in alcoholic liver disease versus HCC. So here are direct-acting agents for hepatitis came out, and you can see that deaths due to HCC are going down, whereas deaths from alcoholic liver disease are going up. And back 10 years ago, Dr. Barbe, Dr. Marsano, myself, treating hepatitis C, Dr. Smart, it was a tough thing to do. All these drugs had complications. Now it's kind of like taking a Tylenol almost. So it's the drugs are expensive, but we're going to wipe out hepatitis C. And I like this article. It was one that I reviewed, and it covers an important topic of insured patients with alcoholic hepatitis. So these patients all have insurance, so they should be able to get good care. And they were followed for 5 years. So 2/3 of them died over that period of time, 44% in the first year. It cost about $50,000 in the first year. Like our patient, 50% were rehospitalized in the first year, and less than 500 were transplanted. So I'm trying to make a story that this is a big deal. The diagnosis of alcoholic hepatitis is a clinical diagnosis. And so it's really a clinical syndrome with the rapid onset of jaundice, with mildly elevated liver enzymes, in the background of heavy alcohol intake. And we'll talk about that in a second. The bilirubin's elevated greater than 3. Actually, for severe, it's greater than 5. But we also have a category of modern alcoholic hepatitis. And the AST is usually mildly elevated, and importantly, the AST to ALT ratio is usually greater than 1.5. And so you can, with alcohol abuse, go through the spectrum of liver disease, from fatty liver disease, classic alcohol steatohepatitis, and here is Mowry's hyaline, and surrounding neutrophils here, cirrhosis, you can see this nodule, and ultimately some patients go on to develop liver cancer, as shown here. So when we say people are a heavy drinker, what do we mean by a drink? And so it's important to try and standardize this. And so a standard drink is 14 grams of alcohol. So that's a can of beer. You can see a much smaller amount of brandy or cognac or wine. And if you go to this NIAAA website, Rethinking Drinking, why you can look this up and get a standardized drink. So again, the diagnosis is a clinical diagnosis, at least in the United States. So when I go to big national meetings, why people from Europe, especially the French, they like to biopsy everybody. We don't. And why don't we? Well, a liver biopsy is 1/50,000th of the liver. So you have huge sampling error. A transjugular biopsy costs about $20,000. And up to 1 out of 1,000 people if you read the literature, can die due to liver biopsy. So we need something different than a liver biopsy for diagnosis. So better biomarkers, a liquid liver biopsy, and better endpoints. And this is highlighted here. So biomarkers and endpoints for me are kind of like Groundhog Day, that wake up and see the same thing over and over again. So here's a New England Journal paper from 50 years ago. And the in-hospital mortality was about the same that it is now. They're dying of about the same thing. And if you read the last paragraph, an emission serum bilirubin greater than 5 that didn't fall at the end of a week was associated with a poor prognosis. So the French think that they discovered this early change in bilirubin and developed the Lilly score, but we actually published it in the New England Journal 50 years ago. So what could biomarkers do that would be helpful? Well, they could help in diagnosis, tell you about severity of disease, prognosis, mechanisms of disease, response to therapy, which would be helpful, or could be actually personalized medicine and companion diagnostics. And we'll talk about this a little bit. So here are the things that we kind of use now: the liver enzymes, the MELD score, the Maddrey's discriminant function. There are a whole bunch of these markers that we use that are on our website, or you can look at the ASLD website. For increasing injury, probably the AST to ALT ratios may be the best. I didn't used to do this until I started doing these alcoholic hepatitis studies, and it actually turns out to be fairly good, but there's huge overlap. So if you look at the people in red here, these are people without overt liver injury who are alcoholics admitted to a rehab unit. So they're being taken care of by psychiatrists. Psychiatrists hate sick people. They don't want to deal with liver disease. So everybody had a normal serum bilirubin, normal nutritional status. these guys are hospitalized with moderate alcoholic hepatitis, severe alcoholic hepatitis. You can see that there's pretty significant overlap here. And our major diagnostic problem is figuring out this patient from this patient. So when you read the literature says, well, if you do liver biopsies, up to 20% don't show alcoholic hepatitis. But that's not because they have something else like autoimmune liver disease. It's because they have burned out cirrhosis without a lot of inflammation going on. So why do we care about that? Well, if you have red-hot alcoholic hepatitis with a MELD of 28, you may benefit from prednisone. So that's going to dampen down the inflammation. And that's what prednisone is supposed to do. On the other hand, if you're a burned-out cirrhotic and have mainly scar tissue there with no inflammation, you're going to get all the bad side effects of prednisone and none of the benefit, and probably get an infection and kill you. So knowing the difference is very important. So we think we have a biomarker that might help in that, and it's called cytokeratin 18. And that's released from epithelial cells with cell death. And when it's released, it's a substrate for caspase-3. So a cleaved form can show you apoptosis. The full protein shows you necrosis. And so a group from Europe looked at this in patients that they biopsied, and they used a cutoff of the full fragment looking at necrosis of greater than 2,000 or a lower endpoint of 641. So they biopsied everybody that they thought might have alcoholic hepatitis, and then they looked at this biomarker. They actually looked at a whole bunch of biomarkers, but this was the only one that was any good. And so if you were greater than 2,000, basically everybody had alcoholic hepatitis. If you were under 641, nobody did. And then there was a gray zone in between where they suggested you should have a liver biopsy done. So they did this in a test cohort, and then they did a validation cohort and showed exactly the same thing. So currently, what are we doing? We're using ALT and AST. So here are groups again. Here you're looking at ALT in our alcohol treatment program patients without any form of severe liver injury, totally normal bilirubin levels. Their ALT levels are higher than the ALT levels of our patients hospitalized and dying of severe alcoholic hepatitis. So our traditional biomarkers of liver injury are worthless for trying to show you severity of disease. So we think this is the marker of the future, and one that we're working with to try and get the FDA to approve. So here's that full protein here. So here are alcohol rehab patients, moderate, severe alcoholic hepatitis. And here's the caspase cleaved form, or apoptosis. So relatively good discrimination. What about personalized medicine or companion diagnostics? So Dr. Jala in immunology in the Cancer Center is looking at pomegranate and berries as an anti-inflammatory agent for both inflammatory bowel disease and liver disease. So what ends up happening? Berries and pomegranate have this stuff here, ellagic acid, that's acted on by your gut flora. And that turns it into things called urolithins. And this urolithin A is highly anti-inflammatory and maintains the gut barrier very well. Problem is, not everybody has the gut flora that's going to convert this stuff to urolithin A. So if you did a study in humans, and they've done this in mice, some animals do great, others, not anything happens. And that's because some have the right bacteria, some don't. So what you would want to do would be test your gut bacteria first, which you can do very easily to see, do you have the right stool or not? And then go ahead and treat the people that have the right gut bacteria. So what are some of the mechanisms for alcoholic liver disease? Well, I've got a simple cartoon here. I'll show you a much more complicated one in a bit. But there's a whole host of mechanisms. And so this is the problem with alcoholic liver disease, is hitting any one target, there are always kind of other ones that will take over. And one of the ones that we've focused on for a long period of time is increased gut permeability and endotoxin leaking across. Now, all of this focuses on injury. And what we haven't looked at very well is regeneration. And this has been impressed upon me. We've been getting explanted livers from guys that have gotten liver transplants for alcoholic hepatitis from Johns Hopkins. We've been working with them. And when I look at those livers, some of them don't have anything but scar tissue in them. So giving them anti-inflammatories isn't going to work. So here's a cartoon of the gut-liver axis. And so this has been our hypothesis for about 20 years, that alcohol alters gut barrier function. You get endotoxemia and other junk from the intestine leaking across into the portal circulation. That stimulates cytokine production. You get liver injury and sometimes intense systemic inflammation and the inflammatory response to SIR syndrome. And that's shown again in the cartoon here with bacterial products leaking across and causing activation of the toll-like receptors. And this is unpublished data from our alcoholic hepatitis network looking at some of these gut-derived factors and things that they activate. So here's endotoxin in alcoholic hepatitis compared to controls. Here's bacterial DNA in your bloodstream in alcoholic hepatitis compared to controls. Soluble CT14 and endotoxin or lipopolysaccharide binding protein. All factors that relate to that inflammatory response. Here's a study that we did in collaboration with Intramural NIH, where we looked at people that came into an alcohol treatment program, again without clinically evident liver disease, and looked at their endotoxin levels as they abstained from alcohol. They came down. We then separated them out into ones that had mildly elevated liver enzymes and those that didn't. And the ones with elevated liver enzymes had increased endotoxin and increased levels of flagellin, another bacterial product. And what happens, again, these bacterial products activate Kupffer cells and monocytes to make TNF, tumor necrosis factor. And we showed that in 1989 when we took monocytes from healthy controls and alcoholic hepatitis patients and stimulated them with endotoxin. The alcoholic hepatitis patients made much more. And as shown here, their serum TNF levels were much higher. So these pro-inflammatory cytokines drive injury and inflammation. Now, I said I'd show you a complicated cartoon. So, again, and this is only a piece of the multiple mechanisms that cause injury in alcoholic liver disease and can ultimately lead to liver cancer. But it provides us with many targets to try and treat alcoholic liver disease. So I look at therapy as kind of a upside-down pyramid. And so everybody should get lifestyle modification. Probably almost everybody should get nutrition therapy. And then we have drug therapy and transplantation. And we'll talk about each one of these individually. And again, a paper that's just been published looking at outcomes of alcoholic liver disease from the 1970s onward, looking at 28-day or 90-day mortality. They're saying it's not getting any better. It's actually gotten a little bit better, but not dramatically. So again, we need new therapies. Lifestyle modification. So I've got my top 10 disease modifiers here. Now, some of these you can't control, like sex. So women are more predisposed to alcoholic liver disease than men. Race, another factor you can't control. Genetics. So genetics, for anybody taking boards, the big genetic test is PNPLA3 that relates to lipid metabolism, the abnormal. Matt Kay's done a lot of work on environmental exposure. But I've highlighted in red 3 things that you can modify. And we'll talk about each one of these briefly. So the first is how much you drink. Can you stop drinking? And there have been a ton of papers out recently looking at this. This is actually from Dr. Klatskin back in 1968, which showed exactly the same thing the new papers do, that no matter where you are in your phase of drinking, if you stop, you'll have a better survival. So our compensated people are in the solid lines here. So here's an abstinent compensated. Here's one that's drinking. Here are decompensated or hatched, one that's abstinent, a group that are drinking. So no matter where you are, stop drinking, and there's a much better chance for improvement. I stuck this on here. So this is a brand new study looking at inflammation in the brain and drinking. And so one of the things that brain scientists are finding now is the drive for drinking is stimulated by neuroinflammation. And that's one of the causes of alcoholism, is that when your liver gets inflamed, why you activate processes that dampen that inflammatory process. When your brain gets inflamed in alcoholics, why that same process doesn't happen very well. And that sustained inflammation drives the drinking process. So what we're hoping is we may be able to come up with something that's anti-inflammatory, that's good for the liver and the brain. And we'll talk about that a little bit. So I think a picture's worth 1,000 words. This is one of my patients, actually back from University of Minnesota, where I did my first alcoholic hepatitis study. So this guy obviously has decompensated liver disease, big umbilical hernia, muscle wasting, big ascites. Here he is a couple years later. You can see same scar or same tattoo here. He's put muscle mass back on, off diuretics, looking great. As I said, things have changed since I started treating these patients. So they used to be skinny little guys. That tends not to be the case anymore. They tend to be often overweight. They've lost muscle mass, so they're sarcopenic, but they tend to have a high BMI. And cigarette smoking is important. So cigarette smoking causes fibrosis. And so this is a critical factor if we can get them to stop smoking. And it's important to remember that alcohol has calories to it. So if you're drinking just 1 or 2 beers a day, that's going to end up being maybe 3,000 calories a week if you don't watch out. And that's basically a pound. So it's a way of putting on weight, which is problematic. So what about nutrition therapy? Well, this is the first study that I've been able to find on any kind of therapy for alcoholic liver disease. The great paper by Arthur Patak in JAMA in 1948. And what they did, it was a kind of revolutionary study. They took guys who were your classic malnourished, skinny alcoholic guys, Skid Row alcoholics, and said, come on into our clinical research center and you can just come here and eat free every day. And their goal was to get them to eat 3,000 calories and 120 to 150 grams of protein. And so here's their survival over a 5-year period of time compared to the historical controls that they were following. So this is actually very similar to data today. And this is what these guys are drinking, an average of about 15 drinks a day. So that's exactly what guys are drinking in our current trials today. So that's over 2,000 calories of empty calories. So there's no protein in there, no minerals in there, no vitamins in there. And so that's why malnutrition happens in these patients. And that's why you get epigenetic screw up due to nutritional abnormalities. So this is a study that was done at the Louisville VA when Carlo Tamburo was here. And we did it, Luis Marzano and I, at our VA in Lexington when we were there. And this was looking at nutritional status in guys with alcoholic hepatitis. And back then, when we brought guys into the VA in a study, we could keep them there for a month. So we did that. And we actually had dietitians that followed them and did calorie counts on them every day. And so we looked at how much they voluntarily ate and then related that to their 6-month mortality. And these guys, on an average, had a bilirubin of 17 or 18. If you were eating more than 3,000 calories a day, even though you were yellow as a pumpkin, you were still going to live. If you were eating less than 1,000 calories a day, you were almost surely going to die. Now, you can not only have macronutrient deficiencies with decreases in protein or alterations in dietary fat, but you can have micronutrient deficiencies. So I bet if I asked Dr. Marzano or Dr. Smart, have they seen a guy with liver disease with a normal vitamin D level? Probably not. So it doesn't happen very often. All of our patients are zinc deficient, and that's something that I've studied for a long period of time. And that plays a critical role in some of the metabolic abnormalities that we see in these patients. So this is a study that I did actually in the late 1970s, where we looked at serum zinc levels in guys with stable alcoholic liver disease, cirrhosis, controls, and guys with decompensated alcoholic liver disease and hepatic encephalopathy. So a stepwise decrease. And this guy's often on both internal medicine boards and GI boards, so this is classic zinc deficiency called acrodermatitis, a skin rash of zinc deficiency. And subsequently, we showed that giving zinc back impacts almost every mechanism of alcoholic liver disease. So we usually give our patients 220 milligrams of zinc sulfate a day. And we showed that they have decreased intake, poor absorption, increased losses. And this is a study that Matt Cave has done that he needs to publish. It's getting old here. But he took cirrhotics and gave them either zinc or placebo. And the ones that got zinc, their zinc levels went up over 3 months, their endotoxin levels went down, and their Child-Pugh score went down. So just giving zinc supplementation to cirrhotics improved their outcome. Now, related to nutrition, and I've talked about this before at Grand Rounds, this is an absolute critical take-home point. Late night snacks are critical. And so once you have cirrhosis of any etiology, your liver doesn't store glycogen well. So you go into a starvation mode overnight and start breaking your muscle mass down. And so if you take a 9 o'clock snack, you'll help stop that. If you take the same snack at 3 o'clock in the afternoon, it's not nearly as effective. And that's shown here, great study from Germany. So in black is the 9 o'clock, and white is the afternoon snack. And this is looking at fat-free mass. So showing that just taking this snack at night helps maintain fat-free mass over time. Now, sometimes people worry about hepatic encephalopathy and giving protein. And this is an old wives' tale. Every talk I give, I tell people not to do this, and it still happens. So do not protein restrict. And actually, our patients need high amounts of protein. And they need to exercise some. So when they go home, I tell them to take 2-pound weights, pump a little iron. They need resistance training to maintain muscle mass. Drug therapy, well, we've tried a lot of things over time. None of these things have worked. One of my favorites, pentoxifylline. Some of the studies are saying that it doesn't work. I have issues with that. I think I know what the problems are. And there's a question about steroids. And much of this came out of this large pivotal trial done in England at many different sites, the STOPPA trial. And what they showed was they randomized people to placebo, prednisone, pentoxifylline, or pentoxifylline with prednisone. And you can see the curves here. They're basically superimposable. Now, what happened, they had really great 1-month mortality, so kind of lower than usual. And that's because they were taking good care of the patients. And that's why I think the pentoxifylline's not showing any effect, is they have other agents that were good for hepatorenal syndrome that they were able to use. The thing that I want to highlight is the 1-year mortality is terrible, 56%. And only about a third of people were abstinent at the end of the year. So early on, you die of alcoholic hepatitis. At 1 year, it's going back to drinking. So our treatment fixes the 1-month mortality, but if you go back to drinking, you're in trouble again. So what about steroids? Well, this is my picture in my office at the University of Minnesota back in 1977, doing my first alcoholic hepatitis studies. Actually, I had a bigger office then than I do now. My marathon time was 3:36. Jimmy Carter was president. Here I am today. I don't do marathons anymore. And President Trump is our president. And here's the history of steroids versus placebo. So, may help, but a lot of debate right now. And people are concerned about potential side effects of steroids, especially infectious. So, what our group has done in helping devise national trials is kind of look at timing on things and how we should be different than we have in the past. So most of the prednisone studies, again, they were given for 30 days. That's how long you could keep people in the VA or how long you could keep people in the clinical research center. So there was nothing magic about 30 days. That's how it happened. And the dose, again, there was no dose-finding study. So what we did in the trial that many of you guys sent us patients on was we randomized people to 2 different groups. So moderate alcoholic hepatitis with a MELD under 20, they're not sick enough to get steroids, but they should get something. So they got either a probiotic or placebo, and the probiotic was Lactobacillus GG, the brand name's Culturelle, one we like. And I know that there's one group that's doing a lot better than the other. We're just about at the end. Then the severe group got either prednisone or an interleukin-1 receptor antagonist for 2 weeks, anakinra, pentoxifylline for a month, and zinc for the whole period. And again, one group's doing better than the other. Whether it reaches statistical significance or not, I don't know. We're finishing the study up actually at the end of this month. What's on the horizon? Well, we have a whole bunch of drugs that are in clinical trials. So again, hepatitis C has been fixed, and so drug companies are now looking at NASH and alcoholic liver disease. And so we've got FXR agonists, obeticholic acid is the one that is the first one that's out there. Probably won't be the best one. Anti-endotoxins, novel PDE4 inhibitors, so pentoxifylline, so weak PDE4 inhibitors. There's a lot of better ones out there. Inhibitors of cell deaths like caspase inhibitors. We'll show you stimulators of regeneration, GCSF. And we are still using inflammasome inhibitors and cytokine inhibitors. So, again, anakinra blocks interleukin-1. And we showed back when there was only bioassays for interleukin-1 that it was markedly elevated in the serum of alcoholic hepatitis compared to controls. And here we're looking at interleukin-1 in alcoholic hepatitis, NASH, toxic and associated hepatitis, and controls. So again, very elevated in alcoholic hepatitis. And so this is work from Dr. Szabo's group, where she looked at an animal model of alcoholic liver disease and gave anakinra. So here's the alcohol-fed animals and the ones that got the anakinra. And the red denotes fat in the liver. And here we're looking at the liver enzyme ALT. So control animals, animals fed alcohol. Here are ones that continue to get alcohol but no treatment. Here are the ones that get the IL-1 receptor antagonists. And again, it helps ALT, TNF, and interleukin-1. What about regeneration? Well, we said there's a big group of people out there that probably aren't regenerating well. So their driver is an inflammation. Their driver is just a sick liver that's not repairing itself. And Anime Deal and Jack Wands both showed a long time ago that alcohol feeding impairs liver regeneration. And so there are a whole bunch of things out there that are being tried for regeneration in alcoholic hepatitis. Now, stem cells haven't worked so far. I don't think stem cells so far have worked in anything that's really been looked at. And part of it has been they go to a bad environment and they die. GCSF, we're going to talk about, and that's causing the bone marrow to release stem cells endogenously, and we're going to be studying that. Our group actually is looking at resolvins, things that come from fat that cause repair process and a decrease in inflammation. So here's a study, it's actually in press from India, where they looked at giving GCSF with N-acetylcysteine or control, which was pentoxifylline. And these were, again, all very sick alcoholic hepatitis patients, better outcome with GCSF. And so that's one of the drugs that we're going to be using in our trial that we just got funded for. What are some other things? A variety of nuclear hormone receptors. One that we have here right now that we're entering patients in this trial is Duret 928 for moderate alcoholic hepatitis. So have somebody with a MELD under 20, give us a call. Antibiotics, NAC, ASK1 inhibitor, prebiotics, probiotics, and artificial liver. So here's this oxysterol 928, the nuclear hormone receptor modulator. And in two groups of NASH patients, you're seeing the cytokeratin 18 go down very quickly, actually within 24 hours with just one dose of the drug, and then comes back up. So if you have any patients with moderate alcoholic hepatitis, why call Matt Cave or myself or our coordinators. What about probiotics? Again, one we like is Lactobacillus GG. And actually, Research Louisville's coming up, and Joe Petrosino, who runs the Baylor Genome Institute, is going to be coming here talking about gut flora as our state-of-the-art speaker. And we collaborate with him on gut flora and alcoholic liver disease. And we've shown that, first, the definition of probiotic is a good bacteria that, when you take it in, does something beneficial to the host. And we've shown that this one bacteria does a whole bunch of things metabolically that are good for patients. And so we have this animal model where we feed animals alcohol for 6 weeks. They get some liver injury. And then we continue them on alcohol, but give them a therapy for 2 more weeks. And here we'll show what we've done with probiotics. So here's the endotoxin levels in alcohol plus Lactobacillus GG. Tumor necrosis factor in the liver up, down with LGG. Neutrophils in the liver up, down with LGG. Liver enzymes improved. Liver histology bad, improved with LGG. And here we've given the animals a GFP E. coli, a fluorescent E. coli, and taken out some of their mesenteric adipose tissue and lymph nodes. So there's translocation in the ones that are getting alcohol, but not alcohol plus LGG. And what we're doing, we've shown that you don't have to give the live bacteria. You give what the bacteria that are actually making. And we think it's a small particle that the bacteria is making. And we're actually trying to get intellectual property on that with Dr. Feng sitting there. So here's our study that's been funded on severe alcoholic hepatitis. So MELD greater than 20, you're either going to get prednisone, GCSF, or our interleukin-1 receptor antagonist plus zinc. So you'll get one of those 3 therapies. And so this study should be activating within the next 3 or 4 months. So we'd love to see your patients go into the study. Lastly, I'm going to mention transplantation. Now, normally when you think of transplantation, you just think of liver transplantation. But you should also think of this, stool. So, alcoholic hepatitis can be transferred or cured, theoretically, at least in animals, with a fecal transplant. And so this is a study in Journal of Hepatology where they had 2 groups, French investigators in the same town, different institution about 2 miles apart. And one group could get good alcoholic liver disease in their animal model. The other group couldn't. And they were getting animals from the same place, their food supply from the same place, water from the same place. And here are the resistant animals, here are the sensitive animals. And they finally figured out it was the gut flora. And so here are the sensitive animals that got now a fecal transplant or put on a prebiotic. You can see their liver fat went down, their liver enzymes went down. Here are studies that we did with Dr. Kirpik in Russia with heavy drinking alcoholics, showing first that their gut flora was screwed up when they came into treatment programs, and if they just got standard therapy, which was abstinence and vitamin supplementation, their liver enzymes kind of stayed the same. If they got probiotics for 5 days, they improved. This is a study that was recently done in India where they did fecal transplants in people with alcoholic hepatitis with very positive results. What about traditional transplantation? So, for most people with alcoholic liver disease, liver services and transplant programs want you to be abstinent for 6 months. The French did a study a few years ago where they looked at a subset of patients with severe alcoholic hepatitis. And again, this was a very small subset of people who had their first episode of alcoholic hepatitis and were thought to be likely good candidates for liver transplantation. And they had very positive results. So this is looking at data from the United States on people who were in similar categories. Their survival rate at 1 year was 94%, which is very good. 3 years, 84%. And their return to alcohol use, very minimal. So, for again, a very rare subset of alcoholic hepatitis patients, they're starting to transplant them because this is the only thing that's going to save their life. So in conclusion, alcoholic hepatitis remains a major health problem in the United States. Abstinence and aggressive nutrition therapy are the cornerstone. New therapies are being validated all the time, and as I say, we're going to be starting this clinical trial in severe patients. We already have one going on in moderate patients. And transplantation's highly effective in selected patients, and we're very interested in what fecal transplant will do in the future. So what happened to our patient? Well, here's his laboratory work when he came in. At the end of a week, his bilirubin was going up, his albumin was going down. Again, his liver enzymes are about the same. We said they're worthless. Creatinine, which is maybe our best liver test for these guys, had gone up considerably, even in spite of the fact that we're very good at taking care of kidney status. And MELD went up dramatically, and he ultimately died of liver failure and infection. So if you are on service and you need to look something up real quickly, or you have an alcoholic and you're trying to get into a treatment program, here are some good resources. So Dr. Marsano has done a fantastic job on our website, so there's a whole bunch of things you can look up there. The AASLD website has over 10,000 learning opportunities in liver disease. NIAAA has two things. This Rethinking Drinking tells basically everything you want to know about complications of alcoholism. And then they have a navigator site if you're trying to find a treatment program someplace. So I'd encourage you to use those. Now, see if there are any questions. Thank you.
So I'm going to ask you to conjecture. Lactobacillus GP works mainly in the upper gut and most of the bacteria in the colon. Do you really think that it matters which probiotic you take with lactobacilli? I mean, I know we can't conjecture without a trial, but patients always ask which probiotics.
Yeah, so the question is lactobacillus magic and the other probiotics aren't? Can you just take any bacteria? So there are actually good bacteria and bad bacteria. So there's some bacteria that you can take that actually make you worse. And so we're doing studies on these. So Dr. Feng is looking at, again, what the different probiotics make that are beneficial. And the talked about different points in the GI tract. So maintaining gut barrier function in the small bowel is actually very important. And our people with liver disease regularly have bacterial overgrowth coming up in the small intestine.
So in the clinical trial, you show that you're going to use the IL-1 antagonist for 3 weeks, and then the toxicant was
The zinc, yeah.
and then the zinc throughout the trial. What was the rationale for selecting that kind of treatment?
Yeah, so the rationale there was you don't get magically better at 30 days or 2 weeks. So what we do is give our anti-inflammatory agents that are very potent for a short period of time. But then we give other agents that help kind of stabilize things for a moderate period of time. And then we give our zinc supplementation, nutritional support that's cheap and we think effective for a longer period of time. So the FDA doesn't like this. So they like you to look at one drug. You know, HIV, they never use one drug. And we know on liver biopsy that alcoholic hepatitis doesn't go away overnight. I can do a liver biopsy on a guy a year after he stopped drinking, and he still may have alcoholic hepatitis in his liver biopsy. So we think different stages of therapy need different forms of therapy. So the question is, we have a double-edged sword in Kentucky here, so our big economy driver is the alcohol industry. And there was just a paper out in the Lancet where they said no alcohol is good for you. And I don't believe that. So, and actually, we're trying to write an editorial of that too. I'm 72. I have a drink every